Welcome to AETCM, the Emergency Medicine channel. Today I'll be presenting a case of 18-year-old female who presented to our ER with complaints of generalized itching and breathing difficulty since last 15 to 20 minutes after consuming a meat roll from outside shop. On initial 10-second assessment, patient was conscious and oriented, patient was obeying commands and talking in full sentences. In primary survey, in airway, there was no swelling of lips, no swelling of tongue or uvula. There was no change in voice, hoarseness or stridor. Coming to the breathing, patient had a respiratory rate of 26 per minute with a saturation of 92% at room air, and on auscultation, bilateral wheeze was present. So at this time, we had connected the patient via oxygen via the facial mask, and also we had given patient injection adrenaline IM, that is 1:1000 dilution. We have given 0.5 ml equivalent to 0.5 mg on the anterior lateral aspect of the thigh, on the mid thigh. And then coming to the circulation part, patient had a BP of 100/70 mmHg with a pulse rate of 70 per minute. At this time, we had put 2 large IV cannulas and patient was connected to IV fluids. Coming to the disability part, patient
also
had
you need to connect to cardiac monitors because you are giving adrenaline.
Patient was connected to the cardiac monitor. And then coming to the disability part, patient had a GCS of 15 out of 15, and on exposure patient was febrile and patient had a GRBS of 109 milligram per deciliter. So after this, we had reassessed the patient, and on reassessing after 5 minutes, still bilateral wheeze was present. So,
when you are approaching a patient with anaphylaxis, first thing in the triage, what will you do? When you are triaging the patient into the resuscitation area, we need to first position the patient. So first, when you are identifying a patient is coming, if you already know that patient is a case of anaphylaxis, first step to be done is what?
Usually first call for help, and then we have to position the patient. Usually we keep the patient in flat position. If patient is having severe breathing difficulty, patient can be kept in propped up position. If there is we have taken the BP, and if the BP is on the lower side, we can elevate the lower limbs and place the patient. If patient is a pregnant lady, then most preferably on the left lateral position patient can be kept.
And the first line management is
always
remove the trigger. Trigger. This patient's trigger cannot be removed, but always you need to mention that trigger should be removed. And as you have told, first treatment is adrenaline. So then only you have started oxygen, then given adrenaline. That is also fine. But ideally, first give adrenaline, then start oxygen. Okay.
So usually adrenaline will be given of a dose 1:1000 dilution will be given, and the dose is 0.5 mg, that is equivalent to 0.5 ml. It can be given IM on the anterior lateral aspect of the thigh, in the mid thigh. So after 5 minutes, we have to reassess the patient, and in our patient, bilateral wheeze was still present. So if the symptoms are still persisting, then we will go with the second dose of adrenaline. So in this patient, we had given the second dose of adrenaline, and then we had reassessed the patient. So in meanwhile, we had taken the sample history also. So in sample history, 18-year-old female, she was already a known case of allergic to the meat, that is beef meat, she was allergic, and she had now presented with complaints of generalized itching along with rashes and breathing difficulty since last 15 to 20 minutes after the injection of a meat roll from outside shop. And then patient didn't have any complaints of dizziness or syncope, no history of any abdominal pain, vomiting or loose stools, no history of any change in voice or hoarseness. Coming to the allergic history, there is a previous allergic history to the meat, but no any known drug allergy is not there. Medical history, no past relevant history is there. In past history, there was one episode of allergic reaction, not anaphylaxis, but a simple allergic reaction was there following intake of beef meat 2 years back. That time she was managed with antihistamines and it got settled. Since then, she was avoiding the intake of meat. And last meal was 15 to 20 minutes back.
So what happened after 5 minutes?
After 5 minutes, we have reassessed the patient, but wheeze had settled down and her tachypnea also had come down.
Okay, when will you call it as a refractory anaphylaxis?
When we have given 2 doses of adrenaline and still the symptoms persist, then we can call it as a refractory anaphylaxis.
Okay, so suppose after giving 2 doses of adrenaline, patient's BP is only 80/40. Will you call it refractory?
Yes.
you can give 2 doses of adrenaline plus a fluid bolus. Even after that, if the patient is in hypertension, you can call it as refractory. Okay, so how much fluid will you bolus?
Usually in adult we give 500 to 1000 ml boluses can be given, and in pediatric dose it can be 10 ml per kg bolus can be given.
Okay, maximum how much fluid can be given?
Maximum up to 2 liters of fluid can be
3 to 5 liters can be given. Okay.
So in our patient had already improved with the second dose of adrenaline.
Okay.
So we had been usually when a patient with anaphylaxis come, first we have to call for help, then we have to position the patient. Third thing is we have to administer injection adrenaline. Fourth is like if there is any hypertension, you have to give the patient IV boluses, like maximum up to 3 to 5 liters of bolus can be given, and reassess after 5 minutes. If the symptoms are still persisting, then we can go ahead with the second dose of adrenaline. And if the patient is not improving with the 2 doses of adrenaline and fluid bolus, then we have to take it as a refractory anaphylaxis.
Okay, so suppose this patient, you told wheeze was there. So what can be given for the wheezing?
If bronchospasm is still there after, like along with adre, if you give, we can also go ahead with the nebulizations. Nebulization adrenaline can be given. Usually we give 5 mg can be given. Otherwise bronchodilators like salbutamol or ipratropium bromide nebulizations also can be given.
So ideally in case of wheezing, it is better to give salbutamol and ipratropium. When will we give adrenaline?
If still
Mostly in case of stridor hoarseness. So in the airway, if your airway, if any problem like stridor or hoarseness of voice, if you are seeing, then we will give adrenaline. How much adrenaline will you give?
Usually 5 mg will be given with the 3 ml NS we can give. Nebulization can be.
And in breathing, if you are hearing some added sounds like wheezing, then only we will be giving salbutamol or
ipratropium bromide can be given. Then in circulatory part, fluid boluses will be given. Then if the patient is already taking some beta blockers, then they would not be responding to the adrenaline. So in those patients, we have to give glucagon injection. Usually we give 1 to 5 milligrams IV over the 5 minutes. And then we can put the patient on infusion of 5 to 15
we will have
micrograms.
to give 1 mg every 5 minutes we have to give till the symptoms subside, then followed by
infusion of 5 to 15 micrograms per minute can be given for the patient.
Okay.
So if the patient goes into the refractory anaphylaxis, we have to keep the patient on the IV fluid should be given. Every 5 minutes you can repeat adrenaline injection until we start the infusion. So usually infusion will be started, this 1:1000 dilution, 1 ml of that will be taken. We'll make into 100 ml solution with 9% NS, and from that 0.5 ml to 1 ml per kg per hour can be kept as infusion. And then we'll be titrating as there is clinical response.
Okay. So if we are giving as an IV bolus, how will you give? Suppose we are, instead of giving IM, you are giving it as an IV bolus dose. How will you dilute?
You can give in 1 ml can be given with made into 10 ml dilution it can be made and given very
then
slow.
It will be 1:10,000.
And then it will be given very slowly, like
that cannot be given slowly. So if you are taking 1 ml of adrenaline with 10 ml of NS, then that will be 1:10,000. That you can't give directly. That will be like giving for cardiac arrest, like 1 mg plus 10 ml NS like a push. That cannot be given directly. Out of this 10 ml, you need to take 1 ml again, and that you will have to mix with 10 ml NS again. So it will be 1:1 lakh. That can be given slow IV because we don't want patient to go into arrhythmias. So that can be given as a IV bolus, but also that should be given by an experienced person because there will be arrhythmias. Yes. Okay. How will you start infusion?
Infusion usually we take 1 ml of this 1:1000 and then we'll make into 100 ml solution, like adding with 99 ml of NS we'll make into 100 ml of solution, and from that 100 ml solution we'll be putting 0.5 ml to 1 ml per kg per hour. Infusion will be started.
You are telling the UK guidelines, but that also is highly arrhythmia prone. So better follow our protocol, the Tintinelli protocol. So in that 1 ml can be mixed with 500 ml NS instead of 100 ml. If you are again mixing that 1 ml with 100 ml NS, it will be 1:1 lakh only. So that also is that will be equivalent to the bolus dose. You understood? Now, first we were mixing 1 ml with 10 ml NS, and now that 1 ml was taken with 10 ml NS. So, if you are directly giving this 1 ml into 100 ml, and if you are giving, that is an IV infusion protocol, but still it is better to give in 500 ml NS, and you can start as 0.5 ml per minute infusion. That means coming around 30 ml per hour infusion can be started. Slow infusion. Anyway, when you are giving adrenaline, continuous monitoring should be there.
So this is how we'll keep the infusion. Then we have to monitor the BP, pulse, heart rate and pulse of the patient. And
If patient is not improving with adrenaline infusion,
we can give the we can also go ahead with the adjuvants also. Adjuvants like H1 antihistamines can be given, like diphenhydramine you can give. Usual dose
no,
is
if
20.
patient's blood pressure is not improving,
You can go ahead with vasopressors and ionotropes. Initially, we'll give a bolus dose, and then we can go ahead with ionotropes. Noradrenaline can be given first, and then you can go ahead with other ionotropes.
okay.
Then adjuvants also can be given for the patient.
Adjuvants are not recommended now. Previously, it was recommended in case of urticaria, but it is not recommended now. Like the steroids and the antihistamines are not recommended now. So when will you try, or when will you think about giving this antihistamines?
If it is a simple allergic reaction, then we can go ahead with this.
Go ahead. If it is an allergic reaction, you can go ahead with it. So how will you give the doses?
Usually, if we are giving diphenhydramine, then it can be given 25 to 50 mg IV over 5 minutes. Otherwise, if it is an H2 antihistamine, then you can give 20 mg over 2 minutes dosage can be given. Then if we are giving corticosteroids, then methylprednisolone is the most preferred one, and in that we give 80 to 125 mg IV. If it is with hydrocodone, then you can go with 250 to 500 mg IV.
In children? So previously, now in Anaphylaxis algorithm, this was not mentioned. So in case of just an urticaria, that too according to previous guidelines, they have mentioned according to the age wise. So we can give, if you are giving hydrocortisone, if the child is less than 6 months, you can give 25 mg. Then 6 months to 6 years, you can give 50 mg. 6 to 12 years, 100 mg. More than 12, 200 mg can be given. Whereas if you are giving chlorpheniramine maleate like avilandol, if it is a child less than 6 months, 250 microgram can be given. Then from 6 months to 6 years, 2.5 mg. Then from 6 to 12, you can give 5 mg, and more than 12, you can give 10 mg. That was the dose for urticaria, simple urticaria. Okay, so how will you tell a patient with urticaria is an anaphylaxis?
Anaphylaxis is will be in acute onset of life-threatening conditions, mainly compromising your airway, breathing, circulation, along with the mucocutaneous changes. That is, the urticarial rash will be there. So when we look in the airway, patient will be having hoarseness and stridor. Coming to the breathing part, patient will be having increased work of labor will be there. Desaturation less than 94%. Patient will develop fatigability and cyanosis. Patient will also have bilateral wheeze. Coming to the circulatory part, patient will develop hypotension, shows the features of shock such as cold clammy extremities will be there. Patient can develop confusion. Patient can also go into drowsiness. So if these things are there, then we can
So everything cannot be there. Any of the. So a patient who is having features of urticaria like itching, rashes, swelling over the lips, angioedema features and all, along with that patient is having some systemic manifestations, then we label the patient as in anaphylaxis. So the systemic manifestations can be respiratory or cardiovascular. Respiratory symptoms, as you told, upper respiratory symptoms or lower respiratory symptoms. Then it can be cardiovascular symptoms like hypotension, this thing and all. Then GI symptoms or central nervous system symptoms like headache, seizures and so. So a patient with urticaria with any of the systemic features we label as the anaphylaxis, and the drug of choice of anaphylaxis always adrenaline. Okay. So how will you differentiate between urticaria and angioedema?
Usually angioedema, urticarial features will be less. So it will be hereditary and
no, angioedema cannot be hereditary, but clinically how will you tell one person is having angioedema, one person is having urticaria?
In angioedema, urticarial symptoms will be less.
Okay, so usually urticaria means there will be itching,
and
pruritus, redness, and the angioedema will be mostly
mostly of
subcutaneous swellings.
will be there.
Okay, and what is a part of urticaria? Is angioedema part of urticaria or urticaria part of angioedema?
Urticaria is a part of
But angioedema. So angioedema can be because of many reasons. So angioedema, one of the most common reason of angioedema is allergic. So if you are taking angioedema as a whole, different you are telling hereditary and all. So if you are taking angioedema as a whole, 90% of the causes because of allergic angioedema, and allergies are because of what?
Any triggers it can be there. It can be due to some drugs, it can be due to food, it can be like
Yeah,
anything.
okay. So it is because of histamine release. And because of that histamine only, patient is having this urticarial features. So so if the cause of angioedema is allergic and it is because of the histamine release, then only this urticarial features will be there. There are several other causes of angioedema. Which all are they?
It can be hereditary angioedema can be there.
That is because of?
That is due to the deficiency of C1 esterase inhibitor. Then there can be ARB AC inhibitors induced angioedema can be there. Idiopathic angioedema also can be there.
Okay, and occurred causes like autoimmune conditions, SLA, lymphoma, and all. So all these are because of what mediator? Bradykinin. So bradykinin doesn't have this urticarial features like itching, rashes, and all won't be there. So that's why these patients are just having edema, not itching. Okay, so AC inhibitors, ARBs, immediately after starting, will they have these triggers?
No.
When will they have? Usually after sometimes they will be having these features will come immediately after starting, or after some triggers, after some trivial trauma or something, that area will become very swollen. So drugs like ACARB induced angioedema even can manifest after months of taking. Okay, and that is bradykinin mediated. Then another one you have told is hereditary is because of
C1 esterase inhibitor deficiency will be there.
Okay, so it is seen in what kind of individuals? Hereditary. It is an autoimmune condition, and it is mostly what is the trigger? Usually in case of
infection, stress,
trauma, and menstruation. Females in menstruating age group will be having this one. So that's why one of the treatment is with androgens like stanozol, danazol, and all is given, and that because menstruation can be a trigger for this one. That is hereditary angioedema. Then other causes acquired. Acquired is this autoimmune conditions, SLE, and everything. Then there are some angioedemas because here we know histamine is the cause for allergic and bradykinin is cause for rest of the angioedemas. Then there are some other cause of angioedema for which the reason is unknown, like angioedema secondary to NSAIDs, angioedema secondary to some other drugs. Okay, and there are some causes like unknown causes and pseudo angioedema, like many causes are there unknown. Like that it will be going. Okay, so urticaria, angioedema, most common cause of angioedema is, if you are telling the drug wise, most common drug causing angioedema will be
penicillin groups, alpha groups,
AC inhibitors, AAB, because we are already told, no. So that is bradykinin mediated, and most you are telling about penicillin mediated. So penicillin can cause urticaria. Most common cause of urticaria is penicillins. Most common cause of angioedema is ACARB. Okay. Then when will you tell that? So we were talking about refractory anaphylaxis. When will you tell that patient is having biphasic reaction because of?
Usually immediately you can get a reaction, and then in certain patients after 3 to 4 hours also secondary reactions can be coming due to the secondary release of the histamines. So
that is why we are observing the patient. Biphasic reaction means symptoms happening after 72 hours. After 3 days, if the patient is having symptoms, that is called as the biphasic reaction. Okay, and what is the difference between anaphylaxis and anaphylactoid reaction? Anaphylaxis usually comes. Initially, you were telling, no, this patient was taking beef. That time, this patient had some urticaria like problem. That's why she stopped. That was anaphylactoid reaction. This time, patient had what? Anaphylaxis. Anaphylactoid reaction is the first reaction. That will be mild only. Like that's why we are giving test dose for medicines. If we are giving test dose for a medicine and patient is developing some itching and all, that is an anaphylactoid reaction. So we need it to prevent that patient having anaphylaxis. Okay, so the first reaction is anaphylactoid reaction. Okay, then what? Then how will Evan, can you tell me about hereditary angioedema?
Hereditary angioedema. Angioedema is basically swelling of the dermis at the level of dermis. So the patient mostly will present with swelling of the face, neck, and extremities, and it can be precipitated due to some stresses like infection, trauma, and other conditions like MI, stroke, CVA. And these patients will have C1 esterase inhibitor deficiency in the plasma. And in these patients, we can suspect hereditary angioedema. Usually they present in first or second decade, and they will usually we can suspect in these patients after the initial treatment for anaphylaxis. Once we give the adrenaline and the patient is not responding to adrenaline, then we will have to suspect other causes for the angioedema. And because the adrenaline is already sensitive for the Ig mediated urticaria or the histamine release induced urticaria. So this is just resistant to the bradykinin or the.
So who is causing the histamine release?
Mast cell
So when the antigen binds to the B cell, the plasma cells will release the IgE, and that IgE will be inhibited by this adrenaline. Okay, then only so that will prevent the histamine release. Okay, so the adrenaline will work only at that level. Okay.
This is mediated by the
bradykinin
or the substance P mechanism. So it is will be refractory to the adrenaline, refractory anaphylaxis and algorithm. So we will give in these patients, we will supplement with the either C1 esterase inhibitor, which is usually not available here, like the human or recombinant C1 esterase inhibitors or the bradykinin 2 receptor antagonist, like icatibant or the like the calantine.
Okay. C1 esterase inhibitor is now here the problem is deficiency of C1 esterase inhibitor. So either we can give the C1 esterase inhibitor if it is available. It is available as recombinant or human. If human is available, 20 units per kg can be given, or recombinant 50 units per kg can be given. If that is not available, then we can consider giving
bradykinin 2 receptor
antagonist. Icatibant is icatibant is acting against the bradykinin. Okay. Okay.
And kallikrein inhibitor is the calantine.
What is the dose of icatibant? 20 microgram subcutaneous dose can be given. Okay. Then.
And if in our area we only have availability of fresh.
Both are not available.
C1 esterase inhibitor. So we can give 2 to 3 units of FFP in our center.
So how will FFP help?
FFP will be containing in this patient's plasma there is deficiency of the C1 esterase inhibitor. So if you take a fresh frozen plasma, it will have the availability of C1 esterase inhibitor and can prevent the reaction.
Okay. And
prophylaxis we can give, especially in females, we can give androgens. Attenuated androgens can be given, like danazol. Danazol can be given.
Okay. This is to prevent the trigger, the menstruation-induced triggers. Okay. And so we are discussing about anaphylaxis. So what is the investigation which can be done in case of anaphylaxis?
For cardiac monitoring, we can take an ECG should be taken, and then mast cell tryptase level can be sent. IG.
And immediately after.
So IG and all will be positive only in case of histamine induced. This patient we are suspecting histamine induced only. Okay, so mast cell tryptase level can be sent. When will we send this level?
Immediately after resuscitation.
In the refractory anaphylaxis, we should send. If it is a refractory anaphylaxis, then we have to send.
Okay, so we need to send immediately after resuscitation,
Within 1 to 2 hours.
1 to 2 hours after, and also after 24 hours. After 24 hours, in order to know the baseline mast cell tryptase level. Baseline, some patients will be having some histamine in the body, so base value we need to know, and after resuscitation and after 1 to 2 hours we need to know. That is investigation of choice. Okay. Anything else? Yeah, thank you.